let's get a little specific. Cathy, 54-year-old patient, rectal bleeding, scope sigmoid lesion, not obstructing, biopsy positive, scan, 3 liver lesions, a little ditzel in the lung, CEA 50. What else needs to be done? Who needs to see that patient?
So for any patients, just as you're describing, the person with rectal bleeding, I like to get the team involved early on. So I would contact my colorectal surgeon to get his viewpoint and make sure that he agrees with me that it's appropriate if that patient is ready for therapy. And we would want to give some neoadjuvant therapy in that setting. However, once again, I would not initiate it until I've spoken to my surgeon.
So they bring him in. Any testing you'd do in this patient? 3 liver lesions, 1 ditzel in the lung, sigmoid lesion.
Well, I would definitely do some MSI testing.
So you're going to do MSI, molecular testing. So
I'm
we're
going to do some
we're
molecular
sending that
testing.
off. That's cooking.
Yeah.
You've got 2 weeks. You can go on vacation before that's back.
Well, it won't necessarily
Not
change
in
my
your place.
treatment.
Yeah, okay.
Okay, but it would help me make decisions in the future if it's needed. I mean, when the tissue is available, you want to utilize it immediately.
Yeah.
You don't want to have to search for it in some warehouse down the road.
Does your liver surgeon need to see this patient?
The liver surgeon probably should see the patient as well.
And then any other imaging?
Well, I think finding out about the lung is the most important because that's going to drive a lot of decision making as to whether it's just liver only.
It's a ditzel.
It's a small one.
It's a
But
ditzel.
it's going to drive, if it's malignant, if it truly is related to colon cancer, it's maybe hard to find out. If you start this patient on FOLFOX in a total neoadjuvant approach, it's going to disappear. Maybe
That's
that proves
bad,
that
right? If it
that's
goes
bad
away,
if it
it's bad.
disappears. It may be hard to find. But you have to at least think about that up front.
Anybody petting this patient?
Yeah, I probably would pet this
What if I gave
patient.
an 8-millimeter periaortic lymph node?
Oh.
on a PET or on
No,
a CT?
CT. They getting a pet now? No? Nobody's petting?
Well, I do think, well,
I'm
there is
petting.
data.
I always pet
I
for
pet.
initial
If I'm-
staging.
Well, for me,
But
if
you
I'm
know,
going to
there
go to
is data.
surgery,
Yeah,
this
I
is
don't
my
always
point.
pet.
I don't know, yeah, but
Right.
but I think if I'm going to surgery, maybe.
Yes.
Yes.
So,
And maybe that lung thing lights up, and maybe
and the
that 8
liver
millimeter.
surgeon would
Maybe.
appreciate it.
They like it, right?
Yeah, only if there is the intent, surgical intent. I
Yeah.
think a PET has been shown in at least a study that
one
it does
study.
impact, at least in one study, that it actually impacts outcome.
Okay.
Because this is how you're going to find about that periaortic lymph node, or even that little ditzel that may actually be, you know.
But the little ditzel's not going to show up on a PET.
It
It's
does.
too
No,
little.
probably won't, right?
It's too
It'll
little.
be PET negative.
Well,
we'll all be
depending on the PET
reassured,
scan,
yeah.
if it's an MD Anderson PET scan, maybe it's a
It'll
little
show up on that one. Yeah,
But
it'll be
no,
quite
no,
positive.
it actually could show up. If it's negative, that doesn't mean it's not cancer. But if it's highly positive, and we've had even 8-millimeter
Yeah,
ditzels
that'll
show
show
up on a PET scan, they may just help guide therapy. That doesn't mean the patient wouldn't be eligible for, targeted approaches. But the management would change a little bit, and the outlook would change.
And
much.
John, what you said about is it bad if the thing in the lung shrinks? That's probably the best test for a small thing. Because if you give them FOLFIRINOX, for example, or FOLFOXIRI up front, or FOLFOX, and it doesn't disappear or shrink, it's probably a benign thing.
Most of us present these patients in tumor boards, but a lot of folks don't, or they don't have access to a tumor board. And so it really often falls to the oncologist to make some decisions about resectability and who all needs to be seen. And I'm just always struck by how much the rules have changed around that over the last, say, decade. When it started, with an isolated liver lesion, and that was the only one we would do, and then didn't matter how many, it was just how much liver you had back. So, from an oncologist perspective, Tara, I'll pick on you. What do you think, are the key elements that oncologists need to be aware of to make that referral?
Well, number one, you have to think of how much disease is in the liver. How is the liver function? Assuming this is a normal liver function. Also, how young is the patient? What is your goal?
Let old people die?
It's not.
I mean, yeah, we're getting there.
But I think you have to realize, are you going to try for cure in this patient, or are you for containment?
Yeah.
And so if you're going for cure, then you have to give your aggressive chemo up front. They have to see the surgeon right away, and so they'll follow the patient, and when it's ready, they'll do the treatment. But now we actually have other therapies. We have the Y90 that you can give with the chemotherapy that just showed some progression-free survival in the liver, not of course in the other places, but if that's the majority of area and someone doesn't want surgery or can't have surgery, that's another option to consider.
What's the wackiest thing you ever took out? Then you can have the floor.
a retroperitoneal lymph node.
So, you know, all our data is around liver.
Yeah,
The
yeah.
in-the-box data
Correct.
is around liver, but you've taken out lung lesions
Oh, yeah.
and stuff. We've done high PEC and, for
Oh, yeah.
colon cancer, right? We've done
We-
peritoneal operations,
Yes.
everybody? Yep. So without a lot of evidence, right? So we get that patient to, as you described, that sort of stage 4, no evidence of disease, some of whom we're curing and some of whom we're not. We'll come back
And
to
when
that.
you
but
have
what were you gonna say?
success, the other patient I remember had a left inguinal lymph node as the only place of recurrence.
Yeah.
And we ended up taking it out
Take that
and
out.
radiating it, and the guy's still free of disease. One thing we have to do is keep our recommendations fairly simple, not because the docs are simple, but we're spoiled. We only do GI cancer.
It's very true,
In most practices, the next patient will have melanoma and they're on nivolumab, and the next patient is a lung cancer. So we
Bleeding
have to keep
pregnant
it-
woman.
Yeah, exactly. So
You're absolutely correct.
I'm-
And we have
I'm-
Well,
experts.
and we know when to sort of bend the rules. Like you see this in surgery too, where you'll have very good GI surgeons who will say, I'm not going after that lymph node, but some of our gang who's been pushing the envelope for a while say, okay, I'll do it for you, knowing a risk benefit, right? So we get to push the envelope more, and we need to forgive our folks that don't and give them that permission, if you will, to do that.